GI unscheduled 1. Okay? Now, just because a patient walks into your office and it's unscheduled doesn't mean they're having a crisis that's a life-threatening emergency. Some patients might have nothing better to do and say, you know what, I got the afternoon off. Let me go see the doctor and complain about my frequent gas and diarrhea and headaches and joint aches, and that's how I'll spend my afternoon. So an unscheduled visit doesn't mean the patient's about to die. All right? But I guess the board wants you to think, well, it's an unscheduled visit, maybe it's a little more emergent. But again, that's not how you're going to make your diagnosis. All right? It's an artificial title to the case. This gentleman, a 78-year-old African-American woman, comes to an unscheduled office visit complaining of left-sided abdominal pain for the past 24 hours. And I'll tell you that the choice of questions is what would you do next? And I give you the following options. Abdominal CAT scan, upper GI, and EGD, upper endoscopy, esophageal gastroduodenoscopy. Upper endoscopy is often abbreviated as EGD. Or colonoscopy, or sigmoidoscopy, or angiogram. Okay? So, left side abdominal pain. Again, when I scan the question and the choices, I don't stop to think about each one because I really don't have enough information yet at all. But I just want to know what the question is focusing on. It's focusing on what diagnostic test, and in other words, I'll need to make a diagnostic differential here and figure out what's the most likely and proceed from there. So let's go back to the case. She's a 78-year-old African-American woman, comes to an unscheduled office visit, complaining of left-sided abdominal pain for the past 24 hours. Patient had a similar episode approximately 3 months ago, which seemed to go away on its own. Yesterday, she notes a mild abdominal pain in the left lower abdomen, which has steadily worsened over the course of the day in association with low-grade fevers. She denies nausea, vomiting. She denies a change in her bowel habits or any blood per rectum. She denies any change in her urinary habits or any weight loss. Her appetite is good. And let me just revise that. Her appetite is good until the last 24 hours. She denies any change. Her temperature is 38.3. Blood pressure is okay. Pulse is a little bit on the fast side. Respirations may be a touch fast. Examination, heart and lungs normal. Abdomen is soft, non-distended. Mild rebound, noted in the left lower quadrant. Okay? Rebound is what I would call a hard finding. As opposed to, it hurts a little bit over here, I got a little bit of gas. That's a soft finding. Fevers, hard findings. Rebound, hard findings. Okay? So there's something going on here. Rebound, what does rebound imply? Peritoneal irritation. Maybe peritonitis, maybe localized peritonitis, but something bad. Okay? Patients with irritable bowel never have rebound. Okay? There is evidence, there's no evidence of diffuse peritonitis, which means, I guess, that on the exam there's not diffuse rebound, there's not referred pain, there's not diffuse guarding. And there's no CVA tenderness. What does that mean? What's CVA tenderness? A code word for? Pyelonephritis. Okay, a febrile person with CVA tenderness, pyelonephritis. A person with hematuria and pain and costovertebral angle tenderness, I'll say they have an obstructed ureter probably. Okay? But pain, tenderness in the left lower quadrant, is that referred pain from the left kidney? Punch the patient in the left kidney, in the left CVA, and if there's no pain, that makes pyelonephritis much lower on my list. That's also why the question tells me no urinary symptoms. Okay? Rectal exam shows guaiac negative stool and no masses. What do you think this 78-year-old patient has? What's your most likely diagnosis? Diverticulitis. Why? Because she's 78, so in all likelihood she has diverticuli. Assume that about 60% of people over the age of 60 who have lived on a Western diet for years have diverticuli. Okay? There's no racial preference of white over black. It's just an age thing. Okay? Younger people can get diverticulitis, and in fact, as we'll see in a few minutes, well, I'll mention it now, younger people, people in their 30s and 40s, who are less likely to get diverticulitis, but when they do, in the infrequent times that they get diverticulitis, it tends to be far more severe. More frequent episodes, more severe episodes, more frequent perforation. Okay? That'll show up as a surgery question. Whereas diverticulitis in the elderly, we'll treat with antibiotics first, and then watch them, sometimes for years and years if they have no recurrent symptoms. A young person with a bad episode of diverticulitis, we treat with antibiotics, and right away we start thinking about surgery, because we know that patient's going to have a rough time with recurrent and severe episodes. So, elderly person, what are the findings? Left lower quadrant, tenderness. Now, there's a whole differential diagnosis of the elderly patient with left lower quadrant findings. Let's say I tell you it's left lower quadrant, and there's pain, there's fever, there's bleeding. Like this patient, right? Excuse me, no bleeding out patient. This patient has pain, fever, no bleeding. What do we think this patient has? Diverticulitis. Let's say I told you the same patient had pain, maybe a low-grade fever, and bleeding. That's diverticulosis? Well, bleeding, yes. Pain, does patient with diverticular bleeding have pain while they're bleeding? No, they might give you a history of diverticular type pain, which is a spasm, crampy sort of feeling after you make the colon contract. How do I make your colon contract? Is it something you do voluntarily? Could you now sit here watching the video or sitting here in the audience say, contract your colon? You can contract your anal sphincters. Could you contract your sigmoid colon? No. What you're trying to do now, what you're all sitting here doing under your clothes, well, I don't know everything you're doing under your clothes, but one thing you're trying to do is contract. You're just contracting your muscles. You can't make your sigmoid contract unless you eat. And then that will start peristalsis, and eventually you get some colonic contractions. Patients with diverticular pain, diverticulosis, will have a typical story of chronic, crampy pain, typically in the left lower quadrant where the sigmoid diverticulosis, that's where most diverticulosis occurs in the sigmoid. That's the kind of history you'll get. Crampy abdominal pain, usually in someone who has chronic constipation who's older. Okay? That's diverticular spasm. That's not diverticulitis. And that's not bleeding. An elderly patient who has pain and bleeding, that doesn't sound to me like a diverticular bleed. Diverticular bleed, we said on one of the earlier tapes, is painless. Arteriovenous malformation, painless rectal bleeding in the elderly. So what diagnosis in the elderly? It gives you pain. Let's say it gives you a fever, low-grade fever. I'm helping you out here. And bleeding, colitis. Okay? Itis. Inflammation gives pain, gives fever, and since the colon is inflamed, the colonic mucosa can get ulcerated and bleed. So what diagnosis gives, what entity gives colitis in the elderly? Is this patient developing acute ulcerative colitis? No. Here I worried about an acute ischemic colitis. All right? Now you say, can infectious colitis present like this? Sure. All right? But again, if the question tells me it's a patient with a history of atherosclerotic disease and no one else around her is getting sick with a colitis-type picture, I would say it's more likely ischemic than infectious. But do I know for sure? No. I'll do stool tests to make sure it's not an infectious colitis. So, in an elderly person, left lower quadrant, pain, fever, and bleeding, I think about ischemic colitis. A colitis, which in the elderly is more common to be ischemic. Let's say I have no pain, no fever, and bleeding. This could be diverticulosis. Okay. Let's say I tell you that the patient has left lower quadrant pain for weeks to months, low-grade fevers, and intermittent bleeding. And let me put another group here, diarrhea. Pain, fevers, pain, left lower quadrant, pain, fever, tenderness, bleeding, diarrhea, bloody diarrhea, elderly. Well, it's colitis. Can this be a chronic ischemic colitis? It can. Can it be an elderly person with onset of ulcerative colitis? It can. All right? But here I'm trying to make the distinction that if it's weeks or months, that's not the classic patient with ischemic colitis. Ischemic colitis is usually going to be an acute onset. Okay? And a patient with diverticulitis. What's their story with diarrhea? Diarrhea? No. There's an inflammatory mass there, so they typically have maybe some obstructive symptoms, not diarrhea. Okay? Patient with ischemic colitis, do they have diarrhea? Yes. Patients with diverticular bleeding, they have diarrhea? No. And a patient with chronic colitis, it makes me suspect a chronic ischemia or an ulcerative colitis in the elderly, again, they do have diarrhea. All right? So, let's just review this. You don't have to memorize charts. It's the last thing I want you to do. I just want to give you 4 or 5 different diseases here that will present with findings in the left lower quadrant. And what's the differential? Well, if they're elderly and they have pain and fever tells me there's an itis. What's in the left lower quadrant of an older person? Diverticular disease. When it's inflamed, we call it diverticulitis. No bleeding, no diarrhea. If I have a patient with an acute onset of left lower quadrant pain, fever, bloody stools, acute in the elderly, think either ischemic or infectious. How do you distinguish? You'll send stool tests looking for infection. Diverticular bleed, you shouldn't ever confuse it with these, because a diverticular bleed, patient's not febrile, patient's not having pain, patient's not having diarrhea, they're having painless bleeding. Okay? And a chronic form of colitis in the elderly, which is less common, I'm going to think about an ulcerative colitis perhaps, or chronic ischemic colitis. All right? Ischemic colitis, about 1/3 of the patients with acute ischemic colitis, about 1/3 of them will go on to have chronic ischemic colitis. Okay? Now, let's say I told you I have a 23-year-old man with left lower quadrant pain, fever, and bloody diarrhea. And it's present for 24 hours. An acute left lower quadrant pain, fever, and bloody diarrhea. Sounds like a colitis in the left lower quadrant, maybe a proctosigmoiditis. And because it's acute, I'm going to think it's what etiology? Infectious. Okay? Why don't I think ischemic in this guy? Because he's 23. If you're 83 and you develop an acute colitis, I'll think about ischemia, although you could still get infection. If you're 23, I'm not going to think ischemia. If it's acute, I'm going to think infectious. Let's say you're a 23-year-old guy with left lower quadrant pain, fever, and bloody diarrhea, and it's been going on for weeks or months. What will I think in that case? There I'll think ulcerative colitis, inflammatory bowel disease, because more of a chronic history, and itis with bloody stools. Okay? Everybody follow that way to think about these? All right, because there's a lot of confusion usually when I talk about diverticulitis and diverticulosis. But know that diverticulosis is just the presence of diverticuli. All right? Only a small fraction of people with diverticuli ever have symptoms from them. And those symptoms from diverticular disease can vary from just some spasm after you eat, a crampy spasm pain, typically in the left lower quadrant. It can be painless bleeding, or it can be diverticulitis. Okay? The pathophysiology of each of these. Spasm is this sigmoid is very hypertrophied, and it goes into spasm and it occludes the lumen, so you get that crampy pain. A bleed from a diverticulum happens when one of these divertics, which is basically just an outbulging, an artery in the dome of the tick gets eroded, and then you have a fresh arterial bleed. That's painless. Okay? And lastly, if you have a diverticulum and the mouth of the diverticulum gets occluded, typically by a fecalith, basically a hard piece of stool, pressure could build up in here, and ultimately you can blow a hole in here and have a micro perforation. What's the consequence of that microperforation? Well, you've just developed a localized peritonitis. And hopefully, it's not more than a localized peritonitis. It just seals itself off in the wall of the colon. All right, so we have what we call an intramural abscess in the wall of the colon. Or you could get it outside the wall, but again, it seals itself off and you have a local perforation. Okay, a contained local perforation and local peritonitis. And if you're really unlucky, you blow a big enough hole and you get spillage all over the peritoneum, what do you get then? Generalized peritonitis. Okay, so the spectrum of diverticulitis could be a little bit of pain with a little bit of fever, all the way to diffuse septic shock, diffuse guarding, diffuse rebound, board-like abdomen, and fecal peritonitis, where you got to take the patient straight to the OR and clean the patient out and put them on broad-spectrum antibiotics. Let's talk a little bit now about the treatment of diverticulitis. And again, it's an itis, it's inflammation, and you have lots of bacteria in the colon. So we're going to treat initially with IV antibiotics if the patient's not critically ill. We'll try and cool them down with antibiotics. If they stay well after that, we just follow them. We don't need to operate on everyone with a single episode of mild diverticulitis. If they've had a free perforation or even a substantial walled-off perforation, that worries us, and we'll cool the patient down with antibiotics and then resect that segment. Okay, we'll do a localized resection. How will we know how localized that perforation is? Again, let's go back to our original question. An abdominal CAT scan is the test of choice in a patient with a diverticulitis episode. It tells you, number one, that the patient has diverticuli. Number two, that there's an inflammatory process around that diverticulum. And number three, it can tell you how widespread that inflammation has occurred. All right? So an abdominal CAT scan was the test of choice in this patient. You don't want to do a sigmoidoscopy or a colonoscopy because you're putting in, remember, you're putting in a scope that's clean. It's been clean since the prior patient, but it's not sterilized. And it doesn't remain sterile the second you put it inside the rectum. And you put it inside the rectum and you're advancing this scope through a colon full of millions of bacteria into an area that just had a perforation. And you're flating air and you're blowing bacteria out into the peritoneum. A bad idea. Similarly, colonoscopy, a bad idea. Okay? So the test of choice here is a CAT scan. If the patient does have free peritonitis at their initial presentation, what I'll do in that case is start antibiotics and take the patient straight to the OR. In the OR, the surgeon will have to make a decision. And that decision will be, can I clean everything up, all this fecal spillage, lavage the patient out, get all that out, and can I then do a resection of the area with diverticulitis and sew the two good ends together? All right, that's called a primary anastomosis. Should I do that? Well, if there's free perforation with a lot of fecal peritonitis, I wouldn't want to have my colon sewn together and pray that in that area where there's just been tons of free stool, that anastomosis will hold. So if there's been a lot of peritonitis, the surgeon will often bring out a proximal loop of the colon as a colostomy and just staple and resect the area that perforated and leave a Hartmann pouch. In other words, if the colon, we're crossing over into overlap with the surgical lectures, but this is important enough because diverticulosis and its complications are very common in this country. And again, the board likes common things, and the board likes things that if you don't treat the patient in the correct way, you're going to have a dead patient. All right? The boards want to make sure you're alert of things that you can make fatal mistakes. So let's say this is your colon. Here's your divertic. The divertic blew open. You got all this fecal spillage. Okay? The abdomen is a mess. You open it up and it looks like a toilet in there. Okay? So what the surgeon does is brings out a loop of bowel to the skin for a colostomy. So the stools doesn't get down here. Tries to resect this whole area and then shuts the remaining distal colon. That's called a Hartmann pouch. Okay? Gives the patient antibiotics. This whole area will hopefully settle down. In a couple of months, once the patient is better, has recovered, you'll go in, you'll take out the colostomy, and you'll make your anastomosis. Okay? The risk of doing a primary anastomosis, doing this in the first stage, is, remember, you just had tons of bacteria here. You've had stool around here. It's very likely that anastomosis will break down. Okay? If it's, on the other hand, a localized walled-off perf, and the rest of the peritoneum is clean, the surgeon can often take out that section and then do a primary anastomosis. Okay? So that's the approach. Mild diverticulitis, antibiotics, and follow the patient. A perforation, antibiotics, take the patient to the OR. Free and do a resection, and if possible, primary anastomosis. If it's free peritonitis, antibiotics, go to the OR, do a resection, and bring out a colostomy and create a Hartmann pouch. Okay? Everybody follow? Okay. Let's talk about a couple of the other diseases in the differential diagnosis for that elderly patient with left lower quadrant pain, and these are discussed in the syllabus. Colonic perforation, well, before you just say colonic perforation, you have to ask, why would a patient have colonic perforation? A couple of scenarios are common. One, not common, but if you're going to have colonic perforation, I would think about diverticulitis, as we just discussed, whether the patient has an obstructing cancer, and because they're trying to peristalse against a fixed blockage, the colon dilates and dilates until it perforates. And the other time you might see a colonic perforation, and so suspected if a patient presents with shoulder pain, localized tenderness or diffuse tenderness after a colonoscopy. All right? Recognize that that procedure has a risk of perforation associated with it. And again, all these you're going to do an abdominal x-ray, look for free air. If there's any question, abdominal x-ray does not pick up all patients with perforation. If you want to know for sure if a patient has a perforation, a CAT scan picks up free air with much greater sensitivity than an abdominal x-ray. Okay? And if there's still a question about a perforation, you could do a gastrograph in enema where you put a water-soluble contrast in through the rectum and see if it leaks anywhere. Okay? Usually it's clear that the patient's had a perforation. They're distended, they're tense, there's guarding diffusely, they may have shoulder pain indicating diaphragmatic irritation. You'll do an abdominal x-ray and then a CAT scan. We talk here also about pyelonephritis, which we mentioned briefly. It is basically a systemic disease. What do I mean by that? It means you can get bacteremia from it. For every case of pyelonephritis you'll see, which can happen in young people or old people, you'll see 100 people, particularly women, who have cystitis. Do folks with cystitis get real sick? No. How does cystitis present? Dysuria, suprapubic pain with urinating, urinary frequency, and very common in otherwise young, healthy women who do not require any additional evaluation other than a urine analysis and urine culture. You give a short course of antibiotics, and no further workup is necessary. If, on the other hand, you have an otherwise healthy young man with the urinary tract infection, then you have to think about why that is. That's not typical finding in a young man, and you have to worry about perhaps urinary tract outflow obstruction, maybe prostatitis mimicking cystitis, etc. But again, young women, we don't need to do workups. Men who have urinary tract infections, cystitis, we do. Now, those are just localized bladder infections. Antibiotics, oral antibiotics, sometimes even for 1 day in high dose or 3 days, can eliminate the infection entirely. Pyelonephritis, on the other hand, is a systemic infection. By definition, it's upper tract and the kidney, and then the bacteria that has gotten into your kidney can easily get into your bloodstream and give you a bacteremia and fever. Urinary tract infections, simple urinary tract infections, will not give you a real sick-looking patient, will not give you a patient with a significant fever, whereas pyelonephritis will. Pyelonephritis, I'm going to look on exam for costovertebral angle tenderness. I'll see a fever. I'll see a sicker-looking patient, and I'll probably see an elevated white blood cell count. Do patients with cystitis, simple cystitis, get elevated fevers and elevated white blood cell counts? No. It's a localized infection. Pyelonephritis, a much more serious infection. Most patients require intravenous antibiotics. All right? And you'll know they're getting better because their urine will clear. You'll do a urine culture on those patients and then some imaging study of the kidney to see that there's pyelonephritis, either a sonogram or a CAT scan, and you'll treat with systemic antibiotics for pyelonephritis. Okay, in here we also discuss a left lower lobe pneumonia. Now, in our 78-year-old woman with true left lower quadrant pain, I really wouldn't think that a left lower lobe pneumonia will cause all the findings that our patient had. But certainly if the pain was higher up in our patient, let's say it was left upper quadrant, you have to remember that the left upper quadrant sits right next to the left lower lobe. Similarly on the right side. If you have a right upper quadrant process, remember that a right basilar infiltrate can give you what looks like abdominal pain. So again, if there's a paucity, if there's not much in the way of GI findings, and they have upper quadrant pain on either side, think about whether the patient may have a small lower lobe pneumonia on either side. Okay, lastly, appendicitis. Something the surgeons say is that on your differential diagnosis in anyone with acute abdominal pain, appendicitis should never be lower than number 2 on your list. Now, why do they say that? Well, because appendicitis is so common, and appendicitis can have so many different presentations. Can it present with left lower quadrant pain? Yes, it can. If you have a very long appendix that swings over into the left lower quadrant, you can have a patient who presents with left lower quadrant appendicitis that looks just like diverticulitis. And it'll be impossible to distinguish. Okay? Appendicitis, it's much easier, of course, if you have it in the right lower quadrant and you get the typical history of appendicitis, which we won't spend much time on because this is sort of bread and butter surgery lecture. And that is, first the patient has a vague, poorly localized periumbilical pain. They develop anorexia, nausea, and usually within 24 hours or so the pain migrates down into the right lower quadrant, McBurney's point, and becomes very focal. Whereas it was diffuse, it's now much more well localized. And that picture is very suggestive of appendicitis. Okay? What's in the differential of that right lower quadrant pain? Again, something you'll hear a lot more about in the surgery tapes. In a young woman, I must worry about gynecologic causes, like pelvic inflammatory disease, like a ruptured ectopic, like a tubal ovarian abscess. Many more women have, quote, unnecessary appendixes taken out than men, because if I have a guy and he has vague pain in here, I'm not worried that I'm going to miss some bad tubal ovarian abscess or PID, etc. And there's not those diseases mimicking appendicitis. Women, on the other hand, have lots of diseases in the right lower quadrant that may mimic appendicitis, namely PID, tubal ovarian abscess, ruptured ectopic. So a lot more women get taken to the OR because there are a lot more diagnoses that can be mistaken for appendicitis. Okay? And I can guarantee you that every patient on the boards, a young woman who presents with what sounds like appendicitis, there will be other choices right next to appendicitis of pelvic inflammatory disease, tubal ovarian abscess, ruptured ectopic. All right? And you'll obviously look for clues for each one of those. All right? Okay. Let's move on to our next case. A 17-year-old white woman who's complaining of bright red blood per rectum and loose stools for the past 2 weeks comes to your office. Okay? She associated the rectal bleeding with 5 to 6 soft or loose stools per day and lower abdominal discomfort. There is no history of antibiotic use, no fever, no unusual travel, and no joint discomfort. And we'll come back to each one of these and why the question specifically elicits that information from the patient. And if the patient had any of those, what you would expect in the differential diagnosis. She's afebrile and her vital signs are stable. Cardiovascular and pulmonary examination are within normal limits. Her abdomen is non-distended with normal bowel sounds. There is tenderness in the left lower quadrant, all right, and it goes back to our differential that we spoke about earlier, about left lower quadrant findings. This is a young person, very different than our 78-year-old woman. There is tenderness in the left lower quadrant. Rectal exam shows bright red blood in the rectal ampulla. Nothing abnormal is otherwise palpated. What am I going to think about in a young woman or man, 17 years old, and it's 2 weeks of symptoms? Now, if I told you it was 2 hours or 2 days, what's the differential diagnosis going to be? Very short. What will it be in that case? Infectious, enterocolitis, or infectious colitis to be more specific. How will I make that diagnosis in an otherwise healthy person who can look quite sick with a fever, a lot of tenderness? How will I make that diagnosis? Stool tests. Okay, what stool tests? In CCS, you can't type in stool tests. All right? They'll say, be more specific. Do you do a cell count on a stool test? Oh, no stool. All right, leukocytes, someone said. Well, I look for leukocytes. Okay, you get a point or so for that. Why do you only get a point for that on CCS? Why wouldn't you get +3 or +5 points? Because there's a leukocyte in the stool. Help you distinguish between inflammatory bowel disease and infectious colitis. No, both of them are going to give you white cells. What can I get more points for? Culture. All right, stool culture for enteric pathogens, for bacterial culture. What else? Ovine parasites. Gram stain, you lose points, because a gram stain on the stool, you're going to see millions of bacteria. I could gram stain every stool in this room, and the things I'd rather do, actually. Everyone will have many, many, many bacteria. All right? I will not find too many parasites, so I will not do a gram stain, but I might do a wet smear looking for ova and parasites. Okay? So I will look for enteric bacteria. I will look for ova and parasites. What else might I look for if the patient had bronchitis treated 2 weeks ago? Stool for Clostridium difficile, okay? Now, the boards might not say, the patient took clindamycin for 6 months for a pulmonary abscess, and then 2 days after stopping clindamycin, developed large volume diarrhea with left lower quadrant cramps. All right? Yeah, that's obviously C. diff, Clostridium difficile from clindamycin. They might just tell you the patient was treated for a bronchitis a few weeks ago. The patient is on no medications, no past medical history, and just recalls that she was treated for a urinary tract infection a week ago. All right? So look for clues that the patient had an infection, then you could assume the patient got an antibiotic for C. diff. The other place you get C. diff, what other kind of patient? So we talked about a patient who has antibiotic exposure. What's another kind of patient? A patient who travels, but travels to the nursing home or travels to the hospital, because C. diff is a notorious nosocomial infection. Nosocomial means acquired in a hospital or healthcare setting. Why? Because whoever's handling that patient doesn't wash their hands and infects the next patient. Okay? So C. diff can be acquired in a hospital or the nursing home even without antibiotics. Okay? So that's C. diff. Which antibiotics are a dead giveaway that the patient's about to see C. diff? If in 12 inches of each other on the boards, you can take a ruler and measure this. With an 11-inch piece of paper, you see the word clindamycin and the word diarrhea. You don't have to read anything else on those 11 inches of paper. That patient's going to have diarrhea. That patient's going to have pseudomembrane. That patient's going to have C. difficile toxin. That patient's going to need metronidazole for treatment. Okay? 5 points you got, 5 questions just because you saw the words clindamycin and diarrhea. That should be an automatic association. All right? Clindamycin is the antibiotic that on a dose-by-dose basis is the most likely to give C. diff. Now, having said that, let's look at it a different way. Let's say I tell you the last 100 cases of C. diff colitis that happened in the hospital, in the clinic, in the doctor's office, what was the most likely antibiotic responsible? Is it clindamycin? No, because I never used clindamycin. No one uses clindamycin if they could avoid it, because everybody give clindamycin is high risk for C. diff. So we don't use clindamycin very often. So the antibiotics that are used far more frequently, even though on a dose-by-dose basis they're not as likely to give C. diff, are the penicillins and the cephalosporins. All right? And almost always on the boards it'll be penicillin or cephalosporin. They might make it so easy as to say clindamycin. If not, penicillin or cephalosporin, C. diff. Certain antibiotics rarely give C. diff. For instance, the aminoglycosides rarely give C. diff. The quinolones, ciprofloxacin, levofloxacin, etc., rarely give C. diff. Metronidazole rarely gives C. diff. After all, we use metronidazole to treat C. diff. What's the treatment of choice for C. diff? I heard vancomycin. That's always the wrong answer. For 2 reasons. Metronidazole. Whenever you see a C. diff patient, metronidazole will be a choice and vancomycin will be a choice. Okay? Why is that? Because they are both effective for C. diff. Why is metronidazole always your first choice? Because 10 days or 2 weeks of C. diff treatment with Flagyl costs about $1.20 for 2 weeks, and 14 days of vancomycin costs about $600. Making up a number, but that's not that far off, okay? So that's number one. It's much less expensive, and we want to think about cost-benefit analysis, and just as importantly, we are worried in a big way in this country about VRE, okay? Something we didn't know about the last time we did Step 3 videotape. Vancomycin-resistant enterococci, which is this superbug that is very difficult to kill. And once we get VRE in the hospitals, we're going to be in big trouble once it starts to arise in any significant number, okay? So the use, and what's caused VRE in the last few years? It's the massive overuse of vancomycin. So there are enterococci that become resistant because, yes, it does kill the C. diff, but it does lead to the emergence of resistant enterococci. So vancomycin is a bad drug to use. Very effective, but a bad drug to use orally for C. diff for those two reasons. Okay, but again, very effective. All right, so we asked about travel history, didn't travel anywhere exotic. Do you need to travel somewhere exotic to get an infectious colitis? Can you travel down the streets in whatever city you are? Go to the cafeteria next door. Go to your local diner. Go to a 4-star restaurant. And can you get an infectious colitis? Absolutely. All right? Sure, it helps if you go to a country that has a high prevalence of traveler's diarrhea in Western travelers. That makes it a lot easier to think about. But you can get it locally as well. All right? So any food, any restaurant, you can get it. Depending on where you come from, if you're coming, you've just traveled to an area, might help you think of various organisms that can cause a colitis. But in general, we'll order enteric pathogens, meaning all the typical gram-negatives in the stool that can cause a colitis, and we'll also look for ova and parasites. Does Giardia, by the way, cause this picture in this patient? No. Why not? This patient has bloody diarrhea and left lower quadrant tenderness. This patient has colitis or sigmoiditis. Where does Giardia live in your gut? Upper GI tract. Duodenum, jejunum. So it causes a lot of upper GI symptoms. Belching, dyspepsia, gas, discomfort, and diarrhea as well, but not a bloody diarrhea, not left lower quadrant tenderness. We used to think you had to go to St. Petersburg in Russia to get Giardia. Now we know you can get Giardia any corner in the United States. Okay? All right. But the tip-offs is for Giardia is the upper GI symptoms. And if they want to make it easy, they'll tell you someone just went camping in the national parks and was drinking the stream water. All right? That's unfiltered, and bears and other animals deposited their Giardia. Okay? Gross but true. And that's why you shouldn't drink unfiltered stream water. Okay? So getting back to this patient, infectious colitis, it's because it's an acute onset. Is 2 weeks imply for sure that it's an infectious colitis? Already is 2 weeks getting on enough time that we should think of a chronic inflammation or a chronic inflammatory bowel disease. 2 weeks is still kind of short for me to think about ulcerative colitis or Crohn's colitis. But certainly if it's 2 months, I'm certainly going to think about it. Okay? So in a young person, acute onset of a colitis, think an enteric infection. If it's going on for a couple of months, then I have to think about inflammatory bowel disease. What are our two inflammatory bowel diseases that we think about? Ulcerative colitis and Crohn's disease. This particular patient, if you had to make a bet, let's say I tell you this patient does, I find out, have inflammatory bowel disease. I ask you which one is it more likely to be, ulcerative colitis or Crohn's disease? What would you bet your nickel on? Ulcerative colitis, because for sure this is involving the colon, whereas Crohn's disease may or may not involve the colon. Ulcerative colitis starts in the rectum, moves up for some varial portion of the colon. If it ends in the rectum, we call it proctitis. Ends in the sigmoid, proctosigmoiditis. Left-sided disease or pancolitis in a continuous, symmetric fashion. Crohn's disease, most commonly, in 75% of patients, involves the ileum and ileitis. So for Crohn's disease, if it's a chronic right lower quadrant pain syndrome with diarrhea, think Crohn's disease. Okay? We'll talk about the right lower quadrant pain differential in a minute. Crohn's disease can involve the colon, but when it does, it often spares the rectum. The rectum might be normal in a patient with Crohn's colitis. The rectum is always involved in ulcerative colitis. And when it involves the colon, it typically does it in a segmental way. Maybe a little inflammation here, a little inflammation here, a little inflammation here. It's not continuous, circumferential, and symmetric. It's segmental. It has skip areas of normal mucosa. That's Crohn's colitis. All right? Crohn's, most patients will have ileitis. Let's talk about the right lower quadrant pain story. Okay? Right lower quadrant findings. Let's say I tell you the patient has right lower quadrant pain, fever, acute versus chronic. I'll tell you that patient has pain, fever, acute, and diarrhea. What disease did I just describe? Very good. Yersinia. It's an acute process. When a patient develops acute abdominal pain with diarrhea, think that something has acutely been introduced into the gut, namely a bug. What bug likes to live in the right lower quadrant, in the ileum? Yersinia. So it causes an acute ileitis. Think Yersinia. Let's say the exact same picture, but the same patient might have pain, has fever, has diarrhea, but it's going on for a couple of months already. What do I think about? Chronic ileitis, think about Crohn's disease. Typically a young person. Okay? What ethnic group? Jews who originate from, whose parents or grandparents originate in Eastern Europe. Those are termed Ashkenazi Jews. Most Jews live in the United States, by far, tend to be originating from Eastern Europe. Okay? Ashkenazi Jews is the highest incidence of both Crohn's disease and ulcerative colitis. Having said that, we see it in Asians, we see it in Indians, we see it in Irish, German, Italian, every ethnic group, but by far most common in young Ashkenazi Jews. Let's say I tell you that there is pain, fever, acute, and no diarrhea. No diarrhea. What do I think about? Appendicitis. Okay? So acute with diarrhea, Yersinia. Acute without diarrhea, better think about appendicitis. And by extension of that, all the other things we mentioned. Pelvic inflammatory disease, tubal ovarian abscess, ruptured ectopic. If it's chronic pain, fever, diarrhea, then think Crohn's disease. How do I make the diagnosis of each of these? Yersinia, how do I make the diagnosis? Stool tests. Crohn's disease, how do I make the diagnosis? With ileitis? Upper GI, small bowel series. Patient drinks the barium. Barium goes through the upper GI tract, which I'm not that interested in. I'm far more interested in following that barium go all the way through to the ileum and showing the inflammation in the ileum. How do I make the diagnosis of appendicitis? You could tell by CAT scan has become more and more sensitive. And if there's any question, the CAT scan is nonspecific, then you take the patient for surgery. All right? It's okay for a surgeon to say, you know what, this past year I took out 5 normal appendices. That's okay if he's taken out about 100 abnormal ones. He says, well, I just took out 5 normal ones and that's all I did all year. There's a problem there. But every good surgeon will tell you, yes, I took out a few normal appendices. And that's okay. I mean, it's maybe not okay for the patient who lost their normal appendix and now has a little scar and an $8,000 bill to show for it. But in general, you want to take out a few normal appendices in order to avoid the missed ruptured appendix. You don't want any young person to die of perforated appendicitis. So when in doubt, we'll take the patient a little earlier to the OR rather than wait for them to show us that they really have appendicitis, because while we wait for them to really declare that it's appendicitis, we're going to miss a couple of perforations. Okay? So there's nothing wrong with going straight from the office or the emergency room, and a patient with a typical history of appendicitis, straight to the OR without going for a CAT scan first. Okay? So that's the right lower quadrant findings, differential diagnosis. Okay? It's about 5, 6 questions you could generate right there. Okay. Let's go back to our patient. We talked about infectious colitis, we talked about inflammatory bowel disease, and we put in here hemorrhoidal bleeding, only because hemorrhoidal bleeding is common. But do we really believe that hemorrhoidal bleeding is going to be associated with loose stools for 2 weeks, 5 or 6 times a day, lower abdominal discomfort? No. No, no, and no. Hemorrhoid, you might have local perianal pain, you might have bright red blood per rectum, but you're not going to see any of these others associated symptoms. Okay. Okay, let's go on to our next question. Our next case. And that is emergency case 6. And this will be the last case we discuss in the GI section. 32-year-old man with a history of alcohol abuse comes to the emergency department with a 2-day history of increasing, constant, dull, epigastric pain that radiates to the back. He has had 2 episodes of emesis without any blood or coffee grounds. Emesis, of course, is vomiting. Patient notes an alcoholic binge yesterday. Now, could this be an ulcer? Sure, it can be. Drinking, sudden onset of pain, epigastric. What kind of ulcer will radiate to the back? A posterior wall ulcer. Either located on the posterior wall of the duodenum or the posterior wall of the stomach, because what's right behind the stomach and the duodenal bulb? The pancreas. Okay? So a posterior ulcer can sound like pancreatitis. He denies prior history of similar episodes. He denies any history of trauma or medication use. Why is trauma relevant? Well, if someone hit you real hard in the abdomen, could you have traumatic pain? Yeah, all right, but there's nothing here to suggest that. How about medication use? Is that relevant? What medication am I thinking about in a patient like this? Am I thinking about vincristine and platinum? Am I thinking about prednisone? Maybe. Am I thinking about NSAIDs and aspirin? Of course. Am I thinking about acetaminophen, Tylenol? No. Acetaminophen, if it causes toxicity, where is that toxicity? Liver. Okay? And that's not usually a painful liver. That's a patient with fulminant hepatic failure and very high transaminases. Let's go back to the question. No medication. Temperature is 37.7. His supine blood pressure is normal. Pulse is fast. And he's somewhat orthostatic, meaning his pulse went up by 20 points. And his systolic blood pressure went down by 20 points. His heart is tachycardic. Lungs are within normal limits. Abdomen has diminished bowel sounds. Tenderness to palpation in the epigastric region. No rebound and no guarding or further tenderness. Rectal exam is guaiac negative. Now, what's my differential in this patient? Can this be, well, what's your most likely? Let's not, remember, for step 2, step 1 especially, the boards want you to think of all kinds of different possibilities, rare diagnoses, etc. Step 2, they want you to be more practical. For step 3, they want you to make the diagnosis so you could move on to do the right diagnostic, confirmatory test, and start treatment. So let's not make long lists. What's the most likely diagnosis here? Pancreatitis. Got a drinker, sudden onset, nausea, vomiting, pain that radiates to the back. Pretty simple. Okay? Can everything in this story be explained by a posterior gastric posterior wall ulcer, a duodenal posterior wall ulcer? Yes. Is there anything that makes that diagnosis unlikely? No. Okay? Can this be biliary colic? What is biliary colic? Means, and let's talk about biliary tract disease causing abdominal pain, which usually you expect to be in the right upper quadrant. We said to go to this area here, but could also present as just epigastric pain. right, so let's review. I'm just going to do this briefly because you'll have this again in surgery. The liver, the right and left hepatic ducts, they merge into the common hepatic duct, and then coming off of the common bile duct is the cystic duct, where the cystic duct joins this bile duct. We call it the common bile duct, which then tapers down. Where does it empty into? Well, it connects with, here's the stomach, and here's the second portion, the duodenum, and it empties into the side wall at the papilla of Vater. Okay? And because there's another very relevant organ to our case, what lies right here? Think in 3D, this is posterior. What do you have here? The pancreas. And here's the main pancreatic duct. And that empties, just imagine this goes behind the duodenal wall, and it empties the exact same place. Okay? That's your biliary tree. That's your pancreatic duct. So, let's talk about what clinical presentation you'll have depending on where stones get stuck. If a stone is right here and just stays there, if I did a sonogram on everyone in this room, looking at your age, looking at your weight, looking at your gender, maybe 10 or 20% of people will have gallstones in here. Does that mean I got to rush you to the OR and laparoscopically remove your gallbladder? No, because if you've never had symptoms, we don't worry about it. An asymptomatic gallstone does not need to be removed. Let's say I see a stone right here. Are you more likely to be symptomatic? Yes. You'll have biliary colic. That slowly building pain that can be very severe, and it's not truly colic. Colic means spasm, severe pain, and then it relaxes. Spasm, relaxes. That colic describes a peristaltic symptom against an obstruction. Small bowel obstruction will cause true colic. Biliary colic is not really the accurate term. The pain builds gradually, doesn't wax and wane. It builds gradually and becomes very severe. If it stays obstructed, the patient will get inflammation, a swollen gallbladder, and will get acute cholecystitis, itis, right upper quadrant pain, and fever. Okay? That's if the stone stays stuck there, and that's acute cholecystitis. If the stone passes and gets out, or passes back into the fundus of the gallbladder, then the patient has pain, and then the pain gradually subsides. That's an episode of biliary colic. All right? So a stone here can cause acute cholecystitis if it stays stuck there, and if it passes, that pain resolves, and the patient will tell you, yes, I have these episodes once a year, once a month, once every 15 years. And then you'll decide, are the symptoms severe enough and frequent enough to warrant an elective cholecystectomy. On acute cholecystitis, of course, we're going to do a cholecystectomy very soon. Let's say the stone gets stuck here in the distal common bile duct. What will this patient describe? What disease does this cause? An obstructed common bile duct causes cholangitis. What symptoms will the patient present with on the boards? Well, there's an itis, so there's pain, there's fever. But in addition, there's obstruction to the common bile duct. So all that bile containing all your bilirubin ain't getting out into your bowel. All right? And it's backing up, it gets into your liver, it gets into your bloodstream, and makes you jaundiced. And the name for this triad is Charcot's triad. Pain, fever, and jaundice. Right there, I know this is more than cholecystitis. How do I know that it's more than cholecystitis? Because when I got a stone stuck here, do I have obstruction to bilirubin from the hepatobiliary system? No. The bile can still happily get down into my intestinal tract. So the patient with cholecystitis does not get jaundice. A patient with right upper quadrant pain and fever, who sounds like they've had a history of gallstones in the past, who is now jaundiced, that patient has cholangitis, which is a much more serious situation. These patients can get very septicemic very quickly. They can die of sepsis within 24, 48 hours. Okay? That's cholangitis. We already got that. Okay? The treatment for cholangitis is, will taking out the gallbladder fix my problem if I have cholangitis? No. What I need to do is somehow get rid of that stone. Acutely, pain and fever, I'm going to give antibiotics, and then make arrangements that if the patient doesn't start getting better quickly, that I'm going to remove that stone. And these days, we rarely have to surgically remove that stone. What we do is put a scope in through the mouth, through the stomach, lead it right next to the papilla. Okay, it's called ERCP, which is a standard test for this test and therapeutic maneuver for this situation. Endoscopic retrograde cholangiopancreatography. Retrograde means we're going to shoot dye up retrograde, up the bile duct and into the pancreatic duct. What will that show me? Well, it'll show me exactly that. As I shoot up dye into that bile duct, I'll draw it so it's visually memorable to you. I fill up on the fluoroscopy that I'm watching. I'm shooting the dye in, and I see the dye fills nicely. Except for that one filling defect. And that is a filling defect. That area is not filling with contrast because there's a stone sitting there. Well, I still have this scope positioned right at the papilla. What I then do is put a catheter through the papilla and then put a balloon past this and drag it out, or put a basket around the stone and grab it out. By some trick that the ERCP person does, we get the stone out. Okay? And it's much easier to get the stone out that way than to do the old-fashioned, really old-fashioned, percutaneous, transhepatic cholangiogram, where the radiologist tries to inject the bile duct and starts putting catheters all the way down through that direction. All right? So cholangitis, antibiotics, and proceed to ERCP if your patient doesn't get better promptly. Okay? Now, with the stone stuck in here, and it's usually at the very distal end, okay? There's a stone here. Besides cholangitis, what else can this stone do to our patient? Produce obstruction of the pancreatic duct. And then pressure builds up in the pancreatic duct, the pancreas swells, and you can get very severe acute gallstone pancreatitis. Okay? And the patient can die from this. How do I distinguish acute pancreatitis from a gallstone from cholangitis? There's a lot of overlap. Okay? Both of them will have pain. In pancreatitis, it tends to be more posterior and more central. Patients with pancreatitis do not usually get jaundice. If there's a tremendous amount of swelling, yes, that can also block the common bile duct. Can a patient have both pancreatitis and cholangitis from one well-situated stone? Yes, but usually it's one or the other. Okay? In gallstone pancreatitis, as with gallstone cholangitis, the treatment will be antibiotics, and if the patient doesn't improve very quickly, remove the stone. Okay? Let's hold the questions till afterwards, okay? So that's gallstone pancreatitis, gallstone cholangitis, acute cholecystitis, which we talked about. Let's get back to our patient. The patient has anything here to suggest biliary colic. Doesn't give us a typical history. But remember, anything that makes you think of pancreatitis, whenever I'm thinking about the diagnosis of pancreatitis, based upon the history and the physical, gallstone pancreatitis, or gallstone disease, I should say, should be right there in the differential, because the pain can be very similar. Could be mid-epigastric, to the right side, to the back, in either one. Okay? Our patient has a history of alcohol the last day. It's a 32-year-old man, not particularly high risk for gallstones. I'm going to think about this guy has either acute alcohol-induced pancreatitis or maybe alcohol-induced gastritis or peptic ulcer, and it's penetrating posteriorly into the pancreas. What do we do in a patient with what I presume will be pancreatitis? Put an IV catheter in. Do I feed the patient? No, I want to rest the pancreas. How do I rest the pancreas? I stop stimulating it. How do I stimulate the pancreas? I feed. Okay? So I make the patient NPO. I give the patient, if they're very toxic appearing, I might give the patient antibiotics. But a simple, uncomplicated case of pancreatitis, we don't need to rush to give the patient antibiotics. What blood tests will I see in a patient with pancreatitis as abnormal? Amylase, and even more specifically, lipase, is elevated in acute pancreatitis. Can a patient with a posterior wall gastric ulcer that's penetrating into the pancreas, can that patient have a high amylase and lipase? Yes, because again, it's causing irritation in the pancreas. All right? Is an abdominal x-ray helpful in acute pancreatitis? Not really. Okay? In chronic pancreatitis, what might I see on an abdominal x-ray? Calcification, because it's chronic pancreatitis, particularly from alcohol, is that the duct in the pancreas gets very strictured, and it gets strictured with specks of calcium. So if I do an abdominal x-ray, I don't see the pancreatic duct on a plain film, but I'll see a string of calcifications across the midline. There's no other disease that gives that string of calcifications in the pancreatic area. That's chronic pancreatitis. In this situation, with this patient with 24 hours worth of pain, chronic pancreatitis is not in the differential. An abdominal x-ray here is a lot less important. Okay. There are other blood tests that can become abnormal with acute pancreatitis. Again, acute pancreatitis is discussed in much more detail in surgery. I just want to make a point that, remember, acute pancreatitis, you can get a patient who gets better in 24 to 48 hours with the conservative treatment we just mentioned, or you can have a patient who's going to be dead in a couple of days because of not only peripancreatic inflammation and pancreatic abscess and necrosis, but also many extra pancreatic complications. And again, I won't go over them all in detail, but I'm particularly worried about developing acute renal failure from pancreatitis and also developing pulmonary problems in the form of either pleural effusions or, much worse, adult respiratory distress syndrome. All right? Every patient with acute pancreatitis typically will get admitted to the hospital because we don't know how they're going to do over the next few days with our conservative management. Now, even though we're going to admit all patients, we have to also ask ourselves, is this alcoholic-induced pancreatitis? Is this gallstone-induced pancreatitis? In this particular patient, we strongly suspect gallstone. We strongly suspect alcohol based upon his history. He was binging yesterday. In a patient with gallstone pancreatitis, who I really want to know if there's a gallstone down here, I really want to know if the patient has a dilated pancreatic duct. I really want to know if in association with that, the patient has a dilated common bile duct. The first test, we talked about the importance of doing an ERCP, but the first test to confirm common bile duct dilatation, give us a look at the pancreas, should be a sonogram. Okay, because it's safe, it's simple, you can have the results right away. If the common bile duct looks perfectly normal and no stones, and the pancreas looks perfectly normal, that doesn't sound like a patient who's going to need to have an ERCP emergently within the next 24 hours. On the other hand, the patient with pancreatitis who has a dilated common bile duct, or a patient with cholangitis who on sonogram has a dilated common bile duct, again, the first test will be a sono to show that, and if the patient doesn't get better, then I will proceed to ERCP. Okay? And with that, we conclude our discussion of GI diseases for Step 3. There you go.